everybody. I'm Nina Crowley. I'm SECA's Professional Affiliations and Education Manager, and I'm here today with Dr. Malvika Juneja. She is an Associate Professor in the Department of Family and Community Medicine at Baylor College of Medicine, and she is the Thread Director for the Social Determinants of Health track, which I'll let her explain to you and kind of how we got connected to bring her here today.
Wonderful. Thank you so much for having me, Nina. I'm thrilled to be here. Hello, everyone. I am, as Nina was mentioning, I am with Baylor College of Medicine. I am in the Family Medicine Department, and I am also Faculty Development Director for about 125 primary care physicians. I teach at the med school, which is a big passion of mine. I'm an educator at heart, and I am responsible for the social determinants of health curricula, which is health equity, getting our students to understand what matters for our patients in the social context and how what we do clinically and their world outside of the clinic, how they're integrated together.
Well, that's great. And I think, you and I first met, through the podcast world and through social media. And I was delighted to be able to speak to your conference.
I was thrilled to see your video. It just spoke to me so much. I know you were talking and it was a very authentic conversation, very different from, what webinars deal with outside. It was a patient perspective. You and Liz were talking about, how a patient who was working with their weight and trying to manage it feels when they get approached by a healthcare provider. And it was just amazing. I thought I wanted you to speak to all my physicians. I wanted you to speak to all my providers for the Primary Care Update Conference. And I think that the presentation y'all created was amazing. I got such wonderful feedback because it was the language was very much patient oriented, and it was you were talking to every single provider that sees patients who are battling with weight every day. So thank you for being in this space. Thank you for your advocacy. It's great. I know the future of medicine is bright when we have folks like you.
Oh, well, likewise. I'm happy, to kind of delve into the world of primary care a little bit more. I know when you and I were talking, I've spent a lot of time in the obesity care community and people who have sort of specialized in that. But I think more than ever, we're seeing the need for all the, medical providers to really be thinking about how obesity affects their patients. And so I'm really interested to pick your brain a little bit more about how primary care gets involved and, what do we need to be thinking about to educate them about the disease state of obesity, the treatments, and then even, in my world now, the outcome measures. We hear a lot about moving beyond BMI, but are they familiar with other measures, body composition? We've talked a little bit about this, so I'm really happy to have your perspective.
No, this is amazing because, like I mentioned before, primary care providers are kind of like in the front lines of medicine, and sometimes the first medical provider that a patient would see. The message that they give their patients, the environment, the sacred environment for a conversation on obesity that they provide in that exam room is critical for the journey of someone trying to. And if you can understand, how we view vulnerable populations, we talk about underserved populations, we talk of folks in the LGBTQ plus space. Obesity is also a vulnerability. So folks dealing with obesity and weight issues are very vulnerable. So I think I really stand behind your mission, Nina, of educating primary care providers because management is, the next step. I think it's a conversation setting. Now, your question was about what primary care providers know regarding, obesity. So I had discussed about how this has changed over the years and that, about a decade ago or even about 6-7 years ago, pre-pandemic, the focus of primary care providers, especially all internists, I would say, family medicine and internal medicine, was about disease management. There's prevention, but when they look at a patient with weight issues, they would say, okay, what has this weight done to this patient's health? And so they would look at how to manage their diabetes or their blood pressure or their cholesterol. And weight is just one of the many things that they have on the side. And maybe, a referral to a nutritionist. It would be perhaps the most well-intentioned provider would very, very rarely would folks, actually offer weight management as the first thing. And because we're trained to contain and improve disease outcomes. So we would steer towards using traditional parameters, labs, perhaps a BMI, etc., to kind of value or we would say weigh the risks of a patient. Body composition, the psychological aspect to dealing would be like secondary, tertiary levels that'll come only after the primary diseases are managed. Yeah. So we've got a little bit of learning to do.
Well, I think that's a great way to put it. And I think, we've talked so much about obesity as a disease state all on its own. And I'm seeing that reflected even, with some of the medication options we have. They're now indicated for obesity as its own, without considering those comorbid health conditions. So how do you think that will affect the way that others are seeing it? Do you think that's a move in a good direction?
Yes. Well, we're headed in the right direction. I think there's a paradigm shift that we all have to get used to. This conversation is now mainstream, and our patients need it. Our patients sometimes demand it. They need it. And we have to get a little bit more literate in being able to hold that conversation and host a range of options for our patients that are safe. But for that, we have to mold and modify a traditional outlook on how weight was or obesity was not the primary diagnosis in the room, and it could be perhaps the only diagnosis in the room if a patient is not having a comorbid health condition.
Yeah, I agree. I think that is a paradigm shift, and it's been very interesting for me being in the field for several years prior, where we just sort of, we really treated obesity with prevention that didn't work so well. And then I worked in bariatric surgery for a long time. And that was, that was a really great treatment for those that needed it. But there was this big gaping, hole in care for where people who needed something more than just diet and exercise, but maybe weren't a candidate or didn't need surgery. And so it's been a really interesting time to have medications. And I do know that it's the talking point that's probably getting people into the office to have that conversation. So everybody's not a candidate necessarily for medication, but I'd imagine for your, for the primary care providers in your world, it's an opener, or that's something new that's bringing them in.
Absolutely. And when I say paradigm shift, it's like actually offering the patient an option versus the patients coming in hoping to have a discussion about it. It's saying, what do you think about having an option to manage your weight? It's a great way to have shared decision making in the room, and at least giving them education about what options they have. It makes them feel respected. It makes them feel valued, and it builds their self-esteem in an invaluable manner.
It's beautiful. But I think Liz would be very happy to hear that perspective, as the patient who had some negative interactions with her healthcare providers in the past. I think that's a real, kind of having that vision of this is who we're working for, shared decision making, and all about that.
And on that note, I'd like to add, actually, I learned this from our medical students who are this age group of physicians in the making. And I observed how much more comfortable they are in these conversations, and that's kind of training a lot of us traditional. You see, I'm 25 years into practice. Some of us more traditionally trained folks as to how to bring in contemporary updates into the exam rooms.
I like that because too, it feels like such a top down. You go through this, you learn from your elders or people who've been in the field longer. But I like that sort of approach, and to hear that they're more comfortable having those conversations. Actually, so
Absolutely.
yeah. Well, so, kind of thinking about something obviously that's important to me is how do we get to our primary care, colleagues, talking to them about, okay, hey, you've got a treatment. It's a powerful treatment. They may start to get comfortable prescribing it. The two things that are very important to me are that interdisciplinary care team. How do we get the word out that they don't have to do it all themselves? Because I think that would be quite overwhelming, not to mention all the other health conditions, but now you're managing a chronic relapsing lifelong condition of obesity. How do we tell them about the other, options out there? And then how do we get people to, not just measure BMI only, or just have that conversation about excess adiposity and looking at muscle mass and some of these other body composition, components?
I think you mentioned one of the, so I have a three-pronged approach, I think, that would best answer that question. And I think you mentioned interdisciplinary care. That is the cornerstone. Like our primary care clinics are often very, I would say, not always staffed with a lot of supportive staff, but are very in need of case managers, social workers, behavioral health therapists. And so I think primary care providers hear the language of interdisciplinary care very, very, they hear it, they love it. That's a great way to start that conversation, saying this is just another aspect of how that care can affect outcomes. I think the second very big conversation that is going to catch their attention is health equity. We've got to keep it open for folks. And if obesity is a vulnerability, this is a population that needs to be supported if we are looking at health equity and strides towards it. And I think the third conversation is just like we talked about. It's all about getting updated with the medications that are in the market right now. And so when we start talking about managing diabetes with the new GLP-1s, SGLT2 medications, we can talk about their impact on BMI, obesity, and then kind of steer that conversation towards, is it really healthy weight loss? What are we talking about? What is healthy weight loss? Where do we go with body composition? So I think you open up the door from the side, and then you can host the main conversation about, let's change the view we have and the lens on obesity while we are on that topic.
I like that too. And thinking, I do think it's so interesting how we kind of often sanction these medications like this is diabetes, this is obesity, knowing very well that there's a lot of overlap in that. And so as a primary care provider, you've been dealing with the GLP-1s for a lot longer for diabetes, right? And so, I think that's a good point to think about, it's that spectrum for everybody. And even if they're not worried about their excess weight or their adiposity, they still have the chance where we're wanting to pay attention to their, fat and muscle and all of that. So that in that regard, it almost zooms out as this is bigger than obesity. It's all the health conditions too, including, metabolic health and diabetes.
I agree. And I think there's a little bit of, we extend it further, because if you're looking to work in underserved care, sometimes you have to start on the patient side to even start discussing what does calorie counting mean? How do you count calories? Where do you look at what labels do you look at? And so keeping physicians very much grounded in that health literacy aspect, and saying, our patients' gaps can be anywhere from being able to decipher a label to actually finding the right medication and then monitoring their health on that medication. That range is very broad, and we've got to have to continue to get medical educators to understand how to approach patients in that spectrum wherever they are and meet them wherever they are, and educate them through the rest of the journey, as well as physicians in the making, so we can continue this conversation with our younger counterparts, our students.
That health equity lens, I think that's really important. I think, that's obviously a big focus for you. And I think, again, that's something we need to be thinking about with obesity, because they do have, disparate trends in weight in these populations. And we do know that, kind of adding them all together makes it even more complicated. So not only that, but also access to medications once they become available, and access to the right therapists and
Absolutely.
counseling.
My message often to my folks and even to my students is, when we talk about trauma or PTSD, post-traumatic stress disorder, sometimes people think trauma is this big thing that happens. Weight management is like micro trauma every day. And so a lot of our folks have underlying guilt, underlying issues with helplessness, and just getting overwhelmed with so many things. And I don't want to Liz's approach on that aspect was just so beautiful that I don't even think I can match that. But I learned from her. And so I'm, with your interdisciplinary approach and your ability to educate primary care providers onto that vulnerability that patients have, as well as the specifics of body composition and the neo medications, I think you are priming them for having safe and inclusive conversations that are offered to our patients, rather than coming as a secondary discussion after a disease per se has been discussed in the room.
I like that. I like thinking about it. I mean, not I like it. I don't like that is the way it is, but that's a good approach. And I think, one thing I learned in the bariatric space was that it may take a provider patient kind of conversation, several conversations, several different providers, several people talking to them over a period of years before they're really ready to kind of undergo that step. So, I mean, there's really no one more important on the team than the most, frontline, most frequent contact person. And so to have that group of people feel empowered about what the options are, how to have those conversations, how to use the language to not alienate the patient or, cause them to sort of retract from care. I think there's really no one more critical in their space than you all.
Thank you. I do cherish being a primary care provider. I carry the flag of primary care very proudly. And I, can't wait for us to be able to continue to push this mission forward in helping our patients feel better about themselves before they can feel better about their disease management. Because it's a wholesome person that you create out of these conversations. And it's very similar to folks who have had, it's like trauma-informed care.
Mm-hmm.
And part of trauma-informed, and is these very, very sacred conversations in obesity management. Yeah.
Well, I am a big stickler, as you know, for language and how we're phrasing everything. And I absolutely am loving the way that you're talking about all of this. So I'm happy that you're at the helm and teaching the future students and, residents and future doctors, how to do this. I feel excited and glad that we met, and appreciative of you coming on here. I think we'll have lots more conversations in this area to come, but anything else you want to leave us with?
Thank you. This is a clinic setting, and I apologize I'm not in my office today, but it's always wonderful to be able to talk to you, Nina, and thank you for all that you do in this space. I hope our audience can feel encouraged, empowered, and we can recruit some advocates for this mission through this podcast.
Well, thanks again, and I'm sure we'll be talking soon.
Thank you for having me.
All right. Appreciate it. Bye-bye.
Bye-bye.